happened in the days and weeks ahead of the publication of the plan. But at that point, 96% of the population were within 10 miles of a vaccination service, it was estimated. Mm-hmm. And if we might look a bit more closely at the principles underlying access, please, to page 30. Paragraph 5.2, we see the scale of the task set out, the biggest vaccination programme in NHS history, and that as at 7th of January, the UK had vaccinated more people than the rest of Europe combined. Looking next, please, at 5.3, the considerations underpinning access were perhaps obviously who should offer a vaccination, the geographical variation and diverse communities, access to transport, and ensuring that NHS services are safe and accessible for people throughout the winter period. And then if we could turn to page 33, please. Paragraph 5.15. Some large sites have been listed above, and it's explained there that these sites were chosen as the mass vaccination centres for those ready to vaccinate large numbers, giving geographical spread. And again, we have this marker of 10 miles within a vaccination service, the aim that by the end of January, everybody will be within that kind of reach. Is it fair to say that at this point, looking at the choice of places and the aim to have everybody within 10 miles of a vaccination service, that at this point, efficiency and scale was the priority for the programme?
I think that's right. If you remember what I said at the outset, the constraint is vaccine manufacturing, i.e. limited supply, which we knew was going to be the real challenge here, not just for the United Kingdom, but for Europe and the rest of the world. And therefore, how do you maximise the protection of the nation? Hence why that sort of shaped the way we planned, the way the team planned the deployment. And I'm sure we'll get to it in a moment. Because obviously community pharmacies are very important in terms of community outreach, which was always also top of mind for me and the team. We were constrained by which ones could actually do the 1,000 doses a week, because when you have limited supply, what you don't want is vaccines sitting in fridges, nor do you want areas that might be able to operationalise quicker through the primary care network actually taking more vaccine because they've been able to get started faster than other areas. Remember, we wanted to get the spread and the equity right, i.e. protect as many people as quickly as possible in the fairest way possible.
So it's about getting geographical spread across the country and also getting vaccines to sites that are actually able to deliver and store
Absolutely right.
the number of vaccines according to the requirements.
Absolutely.
Is it also right that in the early stages of planning, the specific storage needs of the Pfizer vaccine were a constraint?
As you know, one of the vaccines, the mRNA vaccine, needed storage at, I think it was minus 74 degrees. And when it was broken into the smaller packs to get to the front line, again, the fragility and the ability to store and therefore deploy was a huge constraint.
Was it also recognised that it was not enough to just run large central vaccination centres in the long term, because whilst that was the most efficient, it wasn't going to reach all communities? If we could just touch on one final part of the vaccine delivery plan, get that document back up, please, at page 40. This section of the plan deals with drawing on local authorities' knowledge of their communities. local authorities know their communities best and will play a key role. And highlighted there is the expertise of directors of public health and their teams to address diversity and community development. They had a duty, local directors of public health, didn't they, to assist in the proper delivery of the vaccination programme.
Very much so. And again, I thank all those directors. We spent a lot of time engaging with them. You've got to remember, we were, flying the plane while we're building it, right? Before this team came together, there was no, there's no manual, there's no blueprint for how do you deploy a sort of emergency national vaccination program against a global pandemic.
Yes. And thank you, we can take that document down. And that brings us to my next set of questions, which are really about the level of collaboration between local and central government. You attended a ministerial roundtable on vaccine uptake and engaging harder to reach groups in January 2021, on the 8th of January. And I just want to ask you about that meeting. INQ 000499497, please. So this was, if we see on the attendees list on the front page there, attended by you and Lord Bethel, a number of junior ministers, Baroness Dido Harding, and other officials. This was effectively notes of a roundtable discussion with the Department of Housing, Communities and Local Government. And if we could just look at page 2, please, under the discussion section, NZ, that's you, pointing out that while initial rollout takes into account deprivation, we need to ensure we do not miss out on BAME communities, vulnerable groups and others as we progress through the cohorts. And you were keen at that point to hear from others about experiences of rolling out test and trace to harder to reach groups as to how that could be operationalised best in vaccine rollout. And LB, Lord Bethel, and DH, Baroness Dido Harding there. If we just look at the suggestions that came back within that discussion, the third paragraph down, we see DH, some further lessons. On the ground, we faced a huge amount of disinformation, particularly on social media. Found it was often circulating in particular places, able to feed into distrust. Wish we had been more proactive with local authorities and involved them at an earlier stage. Local politicians are very useful and often know which community and faith leaders to talk to. Keith Baz is an example of helpful intervention in Leicester. And the third sector and faith networks are crucial. GP and community pharmacists are by far the most trusted health professionals in their communities. Thank you. We can take that down. So it was a clear lesson from the test and trace programme, wasn't it, that working relationships with the local authorities and local healthcare networks were going to be key to reaching these communities? Very much so.
And just to sort of bring it to life for you, in Hackney, the Haredi Hasidic community, there was a real concern around vaccine hesitancy and not coming forward. And we were approached by the Hatzola ambulance, which is very much part of the community, who said, look, if you let us lead and you, the NHS, support, we think we can deliver against this. So on a Saturday night, I showed up actually with Diane Abbott, who's the local MP. We watched people queuing up to come because they trusted the Hatzola. And within that community, there were lots of Muslim families also coming forward because the community is pretty well integrated. And that was really great to see. We did the same with Brent Mosque. And after, I think it was after Iftar, if I'm not mistaken, the families came in, and it's a trusted place. And that sort of work we were sort of replicating around the country in churches and elsewhere.
Can I ask then about communication with local authorities? You, I think, were made aware at the time of reports of local authorities' concern, particularly in early to mid-January of 2021, that data was not feeding through to local authorities. And just so you have an idea of what I'm referring to, INQ 000499498, please. This is an email chain dated the 10th of January 2021. And if we just could zoom out a little so we can, thank you. This email expresses concerns that really relate to data. And if we look at number one, that locally comms on vaccination delivery and progress can be patchy. At a local level, GPs are communicating with people. The level of communication varies hugely, even within areas. Some frustration in the local tier due to lack of comms on what's happening, with councils not heavily involved in comms and not equipped with the data to do so. And if we just come out there, please, to number two, local councils and directors of public health are not getting data on the rollout at a borough level and aren't being formed or able to accurately judge who isn't coming forwards. And the next paragraph, please. The recognition there, of course, that local authorities will be most useful, as we've recognised, in tackling hard-to-reach groups. Data access is important. Again, it's reiterated there. So, thank you, and we can take that down. Were you aware at the time of the concerns from local authorities in the initial stages that they weren't getting the data, and by which I mean they weren't getting sufficiently specific information on where there were areas of lower uptake within neighbourhoods? They might be neighbourhoods that were next door to each other that had very different levels of uptake, and the demographic information about those pockets of lower uptake so that they could understand who those communities were and then target the programmes that you have been explaining are so helpful towards those communities. And could you explain, please, as well, what you did if and when you became aware of that?
Yeah, no, absolutely. I mean, back to what I was saying earlier, we were, building the plane while we're flying it. And we knew that we will improve our data and, of course, the sharing of data in days and weeks. But what we need to do, of course, initially is make sure that we use the data to the most effective way of its use. What I try to do is make sure I engage with directors of public health, with local authorities, because the more that we can hear from them as to what their needs are, the quicker we can then. And if you recall, as we got further and further into the vaccine deployment program, data sharing became better and better. But if you're asking me, is there a lesson to be learned? Yes, there is. The problem, and I completely get where they were coming from at the time and today as well, is if you're going to try and design a data system by engaging with everyone whilst you've got a virus ripping through the nation, right? You just don't have time, and it's one of those balance of decision-making moments where you have to balance what you're trying to achieve, which is protect as many people as possible, as quickly as possible, by deploying as fast as possible, whilst being limited by supply, versus sort of designing the perfect data system that allows for all the stuff to happen quickly. We knew we needed it. We knew it's a priority, but in all honesty, I don't think we could have done it any better than we did. At the time.
Did the situation subsequently improve as that system
that's my point.
Became more sophisticated?
Absolutely right. And data sharing got better and better because we knew we needed local authorities to be engaged to get to the hard-to-reach groups.
And looking to a future pandemic, I appreciate you left your post and moved on from this work in September 2021, but at the point that you left, were we in a better position?
Much better.
Should a future pandemic require, as it is likely to, the sharing of data between central and local government in that way?
Very much so.
Just then, returning to an issue that you have already mentioned, the use of pharmacies, and it goes really back to that local outreach approach. You were aware that there were concerns from the pharmacy industry and indeed raised in one of those vaccine update meetings by the Prime Minister, concerns about the fact that pharmacies were being underutilised in the early days of the pandemic. If we could look, please, at INQ 000234278. This is a vaccine update meeting. In attendance, we have the Prime Minister, Secretary of State, you, Dame Emily Lawson and other officials and NHS representatives. This is a group that met frequently, didn't it, to discuss updates in vaccine deployment.
Yeah.
And if we have a look at page 2, please, paragraph 2, we've got the Prime Minister there questioning whether enough was being done through community pharmacies. And the explanation that was given by the NHSE was that the NHS had chosen to only use those pharmacies which could commit to distributing over 1,000 vaccines per week, and that the feeling was that average pharmacies would be far less efficient compared to other sites at that time. That was the experience from the flu vaccination programme, and that it was explained that community pharmacies would be critical for reaching harder to access communities. So that was well understood. It was just that they would be switched on, to borrow the terms used in this meeting, as necessary as those communities were identified. Thank you. We can take that down now. And in fact, on the same day, I think you attended 7th of January 2021, same day as the email we've just looked at, a meeting with representatives from the National Pharmacy Association who stressed the importance of pharmacies reaching local communities. So the issue here was that there was a service specification in place, certain requirements, 1,000 vaccinations a week, or also to be open 7 days, certain operating hours. It was only going to be possible for the largest pharmacies to fulfil those specifications in phase 1, certainly the early stages of phase 1. Do you think, looking at this in the round, that the balance when it came to the use of pharmacies, that the balance between efficiency, wanting to reach as many people as possible, as quickly as possible, and reaching groups where there was lower uptake, was struck in the right way?
Yeah, so that meeting was the weekly meeting we had with the PM, and a couple of things to say on that. One, the Emily Lawson plan, as I refer to it, the NHS plan, always had deployment of pharmacy, especially community pharmacies. That was already, to their credit, the team understood that. I had obviously received additional representation, which led to that meeting, by the way, on the same day, that we can do more, Minister, why aren't you using us? And I said, look, let me go through the plan again, and how much more can we pull forward, and credit against to the team. They went through it again, and we looked at what more we can do, because we need it. The constraint, I should say, and we were constrained by the supply. Do you remember what I said at the outset, right? What I can't afford, what we couldn't afford, is to simply want more community pharmacies to come on board when we had limited supply, where the vaccine would just sit in a fridge because they just can't put 1,000 jabs in arms a week. And therefore, we had to strike that balance and say, as long as supply is constrained, we have to deliver a system that can make efficient use of every dose, every vial of vaccine. Once we get to a place where we know supply is no longer constrained, we can go much further than that. And that was, I think, we struck the right balance in the work we did.
I want to move on now to look more closely at the consideration of vulnerable or marginalised groups and the steps taken to increase uptake. Before rollout began, it was plainly anticipated by the government, wasn't it, that the uptake of vaccinations was likely to be lower amongst ethnic minority groups and amongst certain other vulnerable groups. And you understood that as well when you entered your role, is that right?
Very much so.
A vaccine uptake plan was published on the 13th of February 2021, signed off by you and by the Secretary of State. And it set out a plan to address the disparities in uptake and also to represent what steps had been taken to that point. I don't need to repeat those principles which we have so thoroughly covered about the importance of local outreach and of trusted voices. There are a large number of examples of work within the vaccine uptake plan of what was being done or had been done in different regions and communities. Some of it was funded by the £23 million in initial funding in the Community Champions Scheme. I'm not going to attempt to list them, as I say, in the time we have, but they include initiatives like mobile vaccination services, community and faith groups acting as information hubs, networks of professional staff liaising with those working in care homes, videos produced in accessible formats. Is it fair to say that most of those initiatives went back to the principle of using trusted voices, people from the communities that the government is trying to reach who know what the concerns of their community are likely to be? Very much so.
I mean, what we realised quite early on, and if you ask me, one of the learnings is the use of data in the future. Is when we saw obviously what we knew was going to happen, which is lower uptake, especially among ethnic minority groups. The knee-jerk reaction would be to say, let's have more walk-in centres, because maybe these people don't want to make an appointment, give lots of detail, or go online and give lots of detail. When we looked at the data, there were more walk-in centres in those postcodes with the low uptake, within sort of 5 minutes walk, than there was in Stratford-on-Avon, where we had very high uptake. And therefore, we could have easily chucked another £500 million having more walk-in centres, but we wouldn't have solved the problem. We then had to go back and do more research, and the research then very clearly found that actually the best way to do this is, for example, the Community Champions programme, i.e. Clinicians, preferably clinicians, working within the health service who've been vaccinated from those communities, actually then communicating with their local community, at times going door to door and saying, look, I'm from the community, I've taken the vaccine, let me talk to you about the vaccine, how it's been developed, why it's safe, and why it will protect you and your family. And that was a huge success.
Just moving on from those overarching approaches to a particular issue faced by some groups, which is addressed in the vaccine uptake plan, please could we have INQ 000234748 up? This is the vaccine uptake plan, but I think we may have the title page slightly cut off there. If we could go to page 11, please. We're already there. I've been anticipated. Fantastic. So being invited for an appointment. This part of the plan recognises not everyone is registered with a GP. This includes those experiencing homelessness, people who may not live in a fixed location, refugees and those seeking asylum, or simply because an individual chooses not to. And then it's explained that NHS England have worked with partners such as Groundswell and Groundswell and Friends, Families and Travellers, and have launched the Everyone is Welcome in General Practice initiative, which encourages and supports people to register with a GP. Thank you. We can take that down. was this a particular issue, and we can see from the mention of the group, friends, family and travellers, a particular issue within Gypsy, Roma and traveller communities, that of not being registered with a GP?
Yes, but also obviously there are other communities who may not be registered.
Yes, and those with uncertain migration status.
Uncertain migration status, and people who, for example, who actually was the other, I guess the other, extreme of the demographic, who are very wealthy and have chosen historically not to register for public health. But
focusing on those vulnerable groups, is it right that this was a long-standing problem, inclusion in healthcare generally for people with uncertain migration status, Gypsy, Roma, traveller communities in particular, that might be linked to access to a permanent address or might be linked to lack of inclusion in healthcare more generally? It wasn't unique to the pandemic, was it?
No, you're absolutely right.
And I just want to ask you about some actions that were taken by the government. If we could have INQ 000401097 up, please. This is a letter from you dated the 4th of June 2021 to some representatives of access to healthcare organisations, expressing concern essentially about people with uncertain immigration status or vulnerable people being deterred from seeking treatment for COVID-19. And you explain there at paragraph 3 in your response, it's very important people are not deterred from seeking treatment for COVID-19. The department therefore took early steps to ensure diagnosis and treatment from COVID-19 is free for all, including anyone living in the UK without permission. So just pausing there, is that a reference to the charging regime that applied to some forms of NHS treatment, but from which COVID-19 treatment, including vaccinations, was exempt?
That's correct.
But you recognise that there might be a deterrent effect attached to the perception that people may be charged, or indeed that their information might be shared with the Home Office as part of those charging provisions. And just looking, please, at the next paragraph. I can assure you that no immigration checks are needed for overseas visitors when they are tested, treated or vaccinated for COVID-19. And if we could just zoom out and see the whole page, thank you. And NHS providers have also been advised not to share any information with the Home Office or to ask for status of those accessing services related to COVID-19 treatment. The next paragraph makes plain an NHS number is not needed to make a booking for COVID-19 vaccination. But individuals do need to be registered with a GP. Whilst there was an understanding that not everyone was registered, efforts were being made to reach out to those people. Thank you, we can take that down. So it's clear from this letter what the legal position or the government's position was. But my question is, was that sufficiently communicated, not just to healthcare providers who may receive this letter, understand it, file it away, but to the people in those communities so that they knew of their right to be registered, even if they didn't have the right paperwork, and they knew that they weren't going to be charged and that their information wasn't going to be passed on? How was that achieved?
Yeah, absolutely. I mean, actually, obviously, both things. Either that they know that they can come forward and get protected, but also, for the whole country, for it's in the nation's public health interest that we vaccinate all groups. And so we had a whole series of interviews, communications, including with myself, going on to news media and radio that was very much listened to by those particular groups to really reassure that I'm the minister. I'm basically saying to you, look, just walk in and get vaccinated and get protected, and you're safe, and you don't have to fear the state, effectively.
Do you think more could be done in that regard, now and in the future?
I think we did really well in terms of getting the message across that people can just come in and get protected. I don't think we left much that we didn't do. Of course, there's always more that can be done in terms of if you had the luxury of time to plan, but we didn't have that.
Right, I'm going to move on to the interlinked issue of misinformation and disinformation. Just in summary, the inquiry has now heard from a number of witnesses that the government's approach to dis and misinformation was to not engage directly with it, to try to understand the causes of hesitancy. And you explained in your statement that you agreed with this approach, that public engagement with misinformation risks legitimising it. Would you agree, tying together really those issues of misinformation, disinformation, low uptake, that inequalities in vaccine uptake and misinformation, disinformation are both really boil down to trust, that those parts of society that are less trusting of government health initiatives are more likely to look to alternative sources of information and are more exposed to mis and disinformation. It's clear from your evidence and from the evidence inquiries heard from others that lots of efforts were made to try to build that trust and address those issues of uptake and mis and disinformation. But the evidence that the inquiry has received so far appears to suggest, including from experts in vaccine coverage, that despite those efforts, there were still marked disparities in uptake, particularly in respect of some ethnic minority groups. And I think you recognise in your statement lower vaccination rates in some groups still persist, despite the efforts to address inequalities. So why do you think that those disparities persisted despite the efforts that were made?
Yeah, and I would just add one other thing. So we deliberately didn't engage with anti-vaxxers, but we also then deliberately wanted to engage with vaccine hesitant individuals and groups because of that misinformation and disinformation that can impact their decision. And I think, and without having going over each and every initiative, but I think we did some really good things in community, especially engaging with those from the community who happen to be in the health service, clinicians and others, because they would have the sort of the most trusted voice if in the sort of hierarchy of trust with the state. But unfortunately, people still, and you see it even today, right? People think, if you think about vaccines as a whole, not just the COVID-19 vaccine, it's been an extraordinary piece of human ingenuity and innovation to protect humanity from all sorts of disease. Yet there is still today people who choose not to protect their children, say, for an MMR or any other vaccine. So you're always going to have, I guess, residual resistance. But I think we really did put in the hard yards to try and get as much information into the hands of those people who were hesitant, but also making sure that the people who were put out there to talk about it, whether it's Jonathan Van Tam or Chris Whitty or chief nurses, were people that had the credibility, had the scientific credibility as well, and it's not politicians who are going out and saying to you, you must get vaccinated.
I'm going to move on to a separate topic entirely now, which is the cancellation of the Valneva contract. In September 2021, the UK decided to cancel the vaccine supply contract with the biotechnology company Valneva. It had developed a COVID-19 vaccine candidate, which was the only inactivated whole virus candidate within the VTF portfolio. And you received advice about whether or not to go forwards with that contract. If we can just bring us up on screen, please. INQ 4013. And the second page, please. We can see that this is an advice to you and the Secretary of State, at the time, Sajid Javid, regarding Valneva and the decision on termination dated the 9th of September 2021. And if we could go to page 4, please. We should have paragraphs 8 and 9 there. The advice, expert advice from within VTF and DCMO is that it's highly unlikely a significantly better performance would be seen from the vaccine as a primary regimen, or that an alpha variant vaccine would show a much improved boost performance. And then at 9, under the circumstances and having taken advice, we're recommending that we terminate the supply agreement, and then a position is reserved on clinical trials agreement. If we could turn then, please, to page 7 at the bottom. There are some communications at paragraph 25, some advice which arises that we expect that Violet Valneva will be obliged to announce the termination of the contract to the market. We'll work with them on the framing of this and the options around how we'll work with them on alternative uses for the Livingston facility. So that was the facility in Scotland that was being used for production. Thank you. And then please, page 8, paragraph 28, we see the conclusion of this advice that the VTF should engage with Valneva after the market's closed to explain that the UK intends to terminate the supply agreement and engage, we see at C, on alternative plans. So we can take that document down now entirely. So the advice includes then a summary of the effect of the cancellation and in terms of what effect it may have on Valneva's business, and also the business of the Livingston facility, recognising that, as we've seen in that advice, it was the VTF itself that recommended the cancellation. You then considered that recommendation. Concerns have been raised about the cancellation of the contract by a number of Module 4 witnesses, including former chair of the Vaccine Task Force, Dame Kate Bingham, and also Dr. Clive Dix. And concerns have been raised about cruel participant groups as well. Dame Kate Bingham describes the cancellation of the contract as inexplicable, and that it was a shift from positive cooperation with industry to an adversarial approach. It sent the worst possible message, to borrow her language, to any future UK industrial investor or life science partner. So the question is this: to what extent was consideration given to the UK's wider relations with industry when deciding to cancel the contract? That is, the effect on relationships with the pharmaceutical companies that the UK might work with in the future, their willingness to work with the UK if it was considered that contracts taken on at risk might be cancelled in this way. Did you consider that?
The simple answer is yes. You know, I don't know how much of my background, you know, I have a very much a commercial background before entering politics, and on the face of it, and inactivated virus technology should have maybe worked. The VTF didn't deliver their advice out of gut instinct. It was based on evidence. And I attended that meeting with Jonathan Van Tam, the Deputy Chief Medical Officer, and the expert team who took us through the data. You know, as a booster, it just didn't work, even compared to the placebo, right? And therefore, it was a really hard decision to make, but it's evidence-led and based. And that's the only way you should make decisions in government, or even in the private sector, in the commercial world. If I was the leadership at Valneva, the evidence is the evidence. I can't change those facts, and I think it was absolutely the right decision. I hear what Dame Kate Bingham says. I have huge respect and regard for her experience, capability. But in this case, I think we're sort of conflating two different things and delivering the wrong conclusion, i.e., working with the industry and supporting the industry to make us the best place to invest in pharma, in new technologies. That's a very different consideration to just telling the truth to Valneva, saying, look, the data doesn't support us supporting this vaccine, neither as a booster or as a future vaccine, because there are just better technologies. And I think you'd be hiding behind your finger if you think otherwise.
Finally, then, turning to your recommendations or the lessons learned, which you set out in your statement, you describe the use of data as an important lesson learned. Is that to do with the positive lesson to be learned from the sharing of data on a daily basis, daily figures, and transparency with the public, which you think encourage confidence of the public?
Back to where we begun, you remember what I was saying to you about how thorough and well designed the deployment infrastructure was put together by Emily Lawson and her team. By sharing data daily, which was my big passion, was to say, look, we've built this amazing piece of technology with Palantir called Foundry, where the minister can I can see every morning, literally, who's been vaccinated where, almost in real time. By flicking the switch and sharing it with the nation, I actually think was one of the best pieces of innovation in terms of carrying the nation with us. Because remember, we've locked the nation down. Everybody was really struggling and suffering. I couldn't really go on television every night and say, trust me, we've done adequate numbers today. I'll tell you in a couple of weeks' time what we've done. It just wouldn't have worked. When we flicked that switch and opened up the data, and as the nation can see, as we began to really scale the deployment and build the numbers, the sentiment very quickly flipped from despair to hope, and then to belief that we're going to deliver this, we're going to do this, and we're going to do it together. And it then obviously filtered back into confidence and people actually coming forward and getting themselves vaccinated. And so I think that was probably one of the real lessons of this is that level of transparency. Remember, we used to adjust the data every 3 days and say, look, we undershot or we overshot the numbers. And one of the discussions we had before going to daily release of data was to say, are we going to impact the NHS brand if the data isn't perfect? And my very strong argument was it doesn't need to be perfect. We just need to be transparent, because we've got such a great team and such a fantastic plan. We will do this, and we will demonstrate to the nation, and then that positivity will flow through into allowing us to get on with the job for the rest of the deployment.
Mr. Zahawi, thank you. Those are my questions.
Right, there are a few more questions for you. Mr. Wagner, over that way.
Thank you. Good afternoon. I represent clinically vulnerable families, which does what it says on the tin, represents the clinically vulnerable, the clinically extremely vulnerable, and the immunosuppressed. I just have one question to ask you, and it relates to vaccination centres. CVF members report a number of concerns surrounding the safety of vaccination centres for clinically vulnerable and severely immunosuppressed people, which they say presented a practical barrier in some circumstances. And the kind of things that they talk about are poor ventilation at the centres, the distances they were required to travel, which could lead to having to get on public transport or travel in cars with people at close quarters. And they also found that other patients and healthcare workers would frequently remove their masks in the centres. First point is, did you hear about those kind of concerns in relation to the vaccine centres and accessing those centres?
So I, obviously, in my role as Vaccine Deployment Minister, met a number of groups representing the clinically vulnerable, and not least, by the way, and didn't get much of a mention today, but I have to say, we initiated an engagement with MPs and peers, and we'd get hundreds. In the early days, literally almost every MP would be on the call, and I'd be flanked by Jonathan Leach from the NHS and Professor Antti Harnden from the JCVI, and we'd take all questions, including from their constituents who are clinically vulnerable. And actually, that was a great piece of innovation because it was a fantastic radar screen where we picked up stuff very early, including the vulnerability of pregnant women, for example, and prioritising clinically vulnerable with the 70 to 74 age group, i.e. very early on in vaccination. I don't recall concerns around the actual vaccine sites, vaccine centres. Most of the feedback was around what more were we doing to work with the pharma manufacturers, with the vaccine manufacturers, to bring forward some other drugs to protect the severely clinically vulnerable. That was one of the big things that they were worried about. And of course, could we later on make sure that we can vaccinate them if they can't travel at all, for example, but not the point about the vaccine centres of recollection.
Looking back now, and just assuming that those concerns were valid in certain circumstances, do you think there was a failure to ensure that the larger vaccine centres were safe enough, convenient enough, and equally accessible for clinically vulnerable people?
If you're asking me, could we always do more? Absolutely. But my experience of those centres and the people that worked in them, they took their responsibility incredibly seriously and did everything in their capacity to be places that will protect those that are clinically vulnerable. So I think in many ways, I guess, going forward, can we do more? Of course, we can go back and learn exactly how we can do better for the clinically most vulnerable in a pandemic. But those centres were, in my view, really built for safety.
Could you think of ways the vaccination centres could have been better designed for clinically vulnerable people?
I'm not I rely on a lot of experts, right? And I think I'd be answering you or misspeaking if I say to you, oh yes, I'm an expert in this. I can tell you this is what to do. I think it's one for the medical profession. If we can improve that, then we should absolutely look at it. If I'm a decision maker as a politician, I would, in each and every of those cases, I'd say to you, if we're designing for the future, let's talk to the representatives, but also the medical experts.
Okay, thank you.
Thank you, Mr. Wagner. Snoke was usually over that way. There she is.
Thank you, Mr. Zahawi. I hope you can hear me. I represent 4 organisations who comprise the Migrants Primary Care Access Group. I just wanted to ask you a bit more about what you said in your witness statement about editing the vaccine uptake plan that was published in February 2021, and I appreciate that Council's inquiry has taken you to some of those parts. But you specifically said that you provided comments on the draft to include the importance of showing what steps were being taken to address barriers to undocumented migrants and those with unsettled immigration status. But the only reference in the actual plan is to, which Council of Inquiry took you to, was just in relation to the difficulties that people might face being registered with a GP. So there's no specific mention in the actual uptake plan of undocumented migrants or those with precarious immigration status. It refers to refugees and those seeking asylum. So what specific steps were you referring to in your witness statement? What targeted steps, other than those that you've already told us about, for example, your national radio appearance, but what else was there that you actually did?
Well, I think you've just referred to it again. So the other than the plan, we made sure that from the top, i.e. from the minister, myself, and through the organisation, we engaged in outreach, including myself engaging with media outlets, that those particular groups we knew were listening to, were reading, to be able to say very clearly, look, you're hearing from the minister that you can come forward, safe in the knowledge that all we're trying to do is protect you. We're not looking at your documentation or legal status. And that was, I think, probably the most effective thing to do, which is walk the walk, not just talk the talk.
I mean, it's hard to pin down any other examples apart from that which you just referred to about your national radio appearance. You were referred by Council of Inquiry to your letter, the 8th of June letter 2021, which referred to no NHS number being required. But you did need GP registration. And then you set out in that letter, which we've just had up on screen, there was overseas visitors could have registered as temporary patients if they were here for over 24 hours and less than 3 months. But it's complex and hard to understand for people who are outside of those groups. And we have evidence that people were still being refused registration erroneously because of a lack of documentation. So how effective are those communications when the NHS charging and data sharing regimes remained in force?
Again, I would just repeat that we can always learn the lessons of the past, of the pandemic, to do things better in the future. But I did not see any resistance from the NHS leaders to what we're trying to do, which is reach those hard-to-reach groups. Quite the opposite. Incredible support and time in engaging with those yours and other organisations that you represent.
And did you see any impact of the hostile environment health policies on those considerations in terms of impact?
No, I didn't.
So Miss Badenoch just gave evidence just before lunch, and she said that for people who are undocumented migrants or illegal immigrants, that their interactions with the state may be minimal to none. They'd be worried about being deported. And she said in terms, we cannot adjust our health system, in my view, to undermine borders and border securities. That's just something we need to accept. So your positions seem to contradict one another. Either...
I'm sorry, I'm going to have to stop you, Ms. Narek. I didn't give permission for this question, I'm afraid.
Well, my lady, that we say is part of the contradiction between the different.
And also pointing to this witness that there may be a conflict between them. I have this Mr. Zahawi's evidence. Thank you.
Thank you, my lady.
Thank you very much. That completes the questions that we have for you, Ms. Zahawi. Thank you so much indeed. Given your other roles during the pandemic, I'm not sure I can guarantee we won't ask you to help us again. I suspect we may already have done. I don't know, in education or
not yet.
Financial support. Okay, well, keep your fingers crossed. Thank you very much for your help.
Thank you.
I shall break now and return at 3:05.
All rise.
I hope you were warned, Dame Emily, you'll be the last witness today.
I was warned, thank you. I swear by Almighty God that the evidence I shall give shall be the truth, the whole truth, and nothing but the truth.
Could you commence your evidence by giving us your full name, please?
My full name is Emily Jane Ruth Lawson.
Thank you very much. And thank you for attending today and also for the provision of your witness statement dated the 8th of August 24. Dame Emily, can I start, please, with your role and the history of your role in the NHS? After a fairly lengthy career in industry, I think you were a director at Morrison's and then the chief people officer at Kingfisher. You were employed by NHS England from the 1st of November 17.
That's right.
As National Director for Transformation and Corporate Operations. I think you were concerned with the integration of NHS England and NHS Improvement.
Yes, that's right.
Then on the 1st of April 2020, so shortly after the commencement of the government's response to the pandemic, you were made Chief Commercial Officer of NHS England and NHS Improvement, as it then was.
Yes.
Did you, on your appointment as the Chief Commercial Officer, immediately become concerned with the other terrible issues concerning and the difficulties of supplying PPE and ventilators, the whole of that supply chain and procurement and delivery issue?
Yes, in fact, slightly before being confirmed in the role, I got involved in those.
During your time as the Chief Commercial Officer concerned with PPE and ventilators, did you have occasion to work with, and I want to specifically ask you about them, a part of the military called the 101 Logistics Battalion?
I did.
We've not heard much, in fact, any about 101 Log, as they were known. Who were they? Who are they, I should say?
So 101 Log is a logistics brigade, as you've said, in the Army, led at the time by then Brigadier Phil Prosser, now Major General Phil Prosser, and they were brought in March 2020 in order to support the supply chain logistics issues that were going on with PPE, and worked incredibly closely as part of that integrated team through the summer of 2020. And so when I took over, sorry, I might have skipped ahead. But
no, not at all.
When I took over the vaccine programme at the beginning of November, one of the things I did was to go back using the MACA process.
Just stop there. You've just thrown an acronym into the moving parts. MACA, is that the military assistance to civilian authorities process by which the military has to be formally invited to help us out when we're in trouble?
That's exactly right. So that was done through the DHSC. I asked for support again from logistics support from the Army. Obviously, I couldn't specify exactly who or which brigade was sent. And I was obviously delighted 2 weeks later that they decided to send 101 Log and Phil Prosser again.
And did they help you with, and were they of great importance in relation to all these issues, supply and logistics, the logistical planning, because this is an incredibly complex process by which the population of England was to be vaccinated. They acted as vaccinators when you needed extra hands on deck. I think they transformed and set up some of the local vaccination centres. Is that right?
Yes, some of that was not 101 Log, some of that was other Army groups, but having 101 Log in the vaccination team, like right in there with us every day, they performed, many of those functions you said. That operational discipline, as well as the specific expertise in supply chain logistics, was absolutely foundational to how we ran the programme.
I don't wish to intrude into the topic of when and how the military should be invited to assist civilian authorities. It's a bigger issue. But may we presume from what you said that the military assistance you received in relation to PPE and ventilators and in relation to vaccination was of incredible value?
Yes, invaluable.
On the 9th of November 2020, you were then made National Director for COVID vaccine deployment in NHS England. And it's plain from what you say in your statement that that was a hugely important policy role. You were at the head of the pyramid. You also became, did you not, what is known as the Senior Responsible Officer for vaccine deployment and
Yes.
take-up. We've seen references to SRO elsewhere in the paper. What is the SRO?
The senior responsible officer is really the person that has to hold everything together. It doesn't mean they are necessarily commanding all the individual pieces every day, and we can hopefully talk about the multiple pieces that came together to help, not just from the NHS. But the senior responsible officer has to be the person that says we're doing it this way, hopefully having brought everybody with them, and takes responsibility for executing according to the decisions that ministers, and sometimes in this case the Prime Minister, had made, and being a safe guardian of taxpayer money in terms of doing that at the right value for money judgment.
And responsibility is key, isn't it? It's about accountability. The senior responsible officer is ultimately the person accountable for the outcome of, in this case, the vaccination programme.
That's right.
All right. And is that why, and we'll hear witnesses, of course, from Scotland, Wales and Northern Ireland shortly, they were the respective SROs in each of those nations?
Yes.
You were responsible ultimately for every aspect of the deployment. So from the supply chains to the vaccination sites, the running of NHS England insofar as the deployment is concerned, operations, security, governance, reporting, and the not inconsiderable issue of the management and payment and deployment of the workforce. Why was the SRO within the NHS? The NHS is plainly concerned with the routine immunisation. Was that why the SRO was embedded, to use a terrible modern expression, within the NHS, as opposed to, for example, being within the DHSC or having an external head of a task force, or maybe operating this system from within Public Health England? Well, why was it the NHS that was at the heart of it?
So, absolutely, as you say, vaccination is part of the bread and butter of the NHS. We do that every day. We're responsible under Section 7A for discharge of vaccine immunisation and indeed screening programmes. I think even more broadly than that, though, the NHS is unusual. I mean, NHS isn't part of government, but is a public sector body that operates. So the NHS is 1.3 million people who deliver stuff every day. There aren't that many places in government, whether they're arm's length bodies like NHS England or, for example, HMPPS in the prison service, that actually run things. And the critical, in my view, one of the critical parts of the vaccine deployment programme is we were operators figuring out how to effectively deploy something incredibly important to the health of the country, and where health and then local relationships, which the NHS also has, were absolutely central to our success.
And I suppose a lot of it comes down to the sheer scale and ability of the NHS. It's a massive administrative body as well as a health service provider. And it's also within and without government. It covers a very broad range of functions.
That's right. And I mean, it's multiple organisations, and I'm sure, I know you've addressed the complexity of the NHS setup previously, but so within that you have commissioning, you have delivery, you have policy and strategy making. We can come back to some of the pieces we had less of, like supply chain expertise, for example, but this is the NHS brand, and that consistent relationship we have with each other has proven to be, through this, an incredibly powerful force for getting things done, for creating an aligned purpose.
And the NHS, as a unitary body across England, and of course there's similar situations, similar systems in the devolved administrations, is an incredibly effective, beneficial body, both in terms of providing health services, but also by way of brand recognition and countering, in this case, vaccine hesitancy.
I think that's right. There is an and there in that the NHS is an incredibly powerful, highly recognised brand. And for some groups, as we learnt during the pandemic, it's not, no organisation is really trustworthy because of previous experiences. So yes, it's incredibly powerful. And we had to reach outside the NHS and its heavy brand in order to make sure we were reaching everybody. It was both at the same time.
We'll look at that in a moment. And so may we presume, Dame Emily, that you would strongly recommend that in the face of a future pandemic requiring national population level vaccination, it is the NHS that leads the charge in the way that it does with routine immunisation?
Yes, I would.
Can I just ask you a little more about that, Dame Emily? You had a commercial or a private sector background. To what extent did that help you? Do you think you said the NHS should lead in future, but the NHS had the advantage in this last pandemic of people like you who'd also had substantial private sector experience?
Honestly, I think it was really helpful. I think I was incredibly lucky to be given this job, but I was also in the right place at the right time, and all of that experience I've had, you know, through my scientific background, through the private sector, all of that came together to enable me to do a good job leading all these different people with hugely valuable and different forms of expertise. So it is both. I think a public sector ethos of wanting to deliver a life-saving intervention was equally powerful, if I would put it that way.
Thank you.
When you became the national director on the 4th of November, I think you were asked on the 4th of November, you were appointed on the 9th.
Yes.
When you were appointed, presumably a great deal of planning work and practical measures had already been put into place.
Yes.
And therefore, presumably, a great deal of work had been done on identifying vaccination sites, the design of the pods, as we'll see in a moment, the supply chain arrangements, the booking system, the recording of vaccinations individually, and on communications. So the structure was in place. But what were the three main challenges in terms of getting it from that position on the 9th of November to actually delivering the first vaccination on the 8th of December?
So the week that I took over was the week that Pfizer data was published saying that the vaccine was effective. So it went from being a theoretical possibility to actually this was going to happen. And as you mentioned, there were lots of component parts that had been worked through, so the pod system, et cetera, because of the level of uncertainty, which actually persisted through November, the novelty of this vaccine, a lot of final decisions had yet to be made in terms of, particularly given how the vaccine might be able to be transported, would have a major impact on what centres could actually distribute it, what training people would have to have, et cetera. All of that remained to be done.
So just pausing there, by way of example, Pfizer had to be kept at -70 or thereabouts. It wasn't, of course, given authority until the 2nd of December. And at the beginning of November, you wouldn't know, therefore, what ultimately you'd have to put into place in order to be able to cope with that requirement. Yes,
so we had to develop options. And that novelty, having never seen this kind of vaccine before, and the fragility of an mRNA vaccine surrounded by its lipid molecules, meant that until we saw the data from Pfizer, until MHRA provided that authorization on the 2nd, we didn't have clearance to transport it at anything other than -70. -70 is not a standard way to transport medicine, so there wasn't an established supply chain to do that. And we had the tension between the cohorts that were most at risk that JCVI had defined, so cohort 1, so care home residents and workers, and then group 2, which was those over 80 and health and other social care workers. The only place we knew in mid-November we would be able to get the vaccine to were hospitals that had -70 freezers.
We'll come back to that in a moment, and why, therefore, you focus on hospitals at the beginning of the deployment process. In relation to staff, were you enabled to employ at risk? That is to say, look forward and say, well, we're going to need this number of staff for the purposes of the rollout starting the beginning of December, we can pay for their deployment and we can bring them on board? Or did you have to wait?
No, we were able to identify, and the team had done quite a lot of work before I arrived on how many staff would be needed depending on the volume of vaccinations. What we couldn't do is train them, because obviously what was going to need to be true about how you dispense this vaccine wasn't known until the beginning of December. But the theoretical modelling, the specific roles within a vaccination centre, for example, that was all created theoretically around the time that I joined.
The third area you identify in your statement as being particularly challenging was that of process, and you know where I'm going to. You refer on multiple occasions to the fact that, to use the terrible expression, the deployment process had multiple stakeholders. You appear to have spent a great deal of time speaking to other people, updating other government departments, getting input from the DHSE, the Vaccine Task Force, the Cabinet Office, the Treasury, Number 10, DLUC. I could go on. Was an optimum process of governance and reporting to other parts of the government in place when you joined, or did you have to try to alter the reporting obligations?
I needed to alter it. I spent the first week doing what I was asked to do and attending all of the different meetings because I wanted to learn as much as anything else. And one of the things I noted in those meetings is everybody would ask me how they could help, right? Everybody wanted this to be successful. And I'd say, you know, the one thing you can do is cut down on the number of governance meetings I'm going to. And everybody would say, absolutely, definitely, we should simplify that. But not mine. My meeting's really important. So I got to the end of the week, added up that I had spent 24 hours just in governance meetings, so not actually fixing anything. And I said, no, we need to streamline this. We need absolutely to be held to account. This is one of the most important things the country's doing, and it's a lot of taxpayer money. I totally get that. But can we do it in a way that also enables us to get stuff done? And let's put those two needs together.
You must have reflected why, perhaps in our system of governance, perhaps in many systems of governance, there appears to be a need for so many meetings, so many rolling iterative submissions to be made, so many updates, reports, meetings with stakeholders, actions. It appears to become a very heavy written process of bureaucracy imposed on you trying to put something incredibly valuable and practically important into place.
Yes, and I think there are several things there. One is just the level of importance. It was so important to everybody. The other was the funding, as I've mentioned. And then the other thing is each of the groups that you mentioned had a different, sometimes overlapping, but different need, right? VTF needed to know that what they were doing was actually going to happen. The Cabinet Office had an overall assurance role. Number 10 obviously wanted to make sure this was going to be successful. The Department of Health had a critical, policy and oversight role. It wasn't that HMT needed to take charge of the money. It wasn't that any of those things was unreasonable. It's that they were additive rather than complementary, and I thought there was an opportunity to streamline that.
So you did?
So, yes.
You had, within the NHS England structure for vaccine deployment, a mission statement. And
yes.
The inquiries noted that the Vaccine Task Force had a mission statement. They appear to be associated with successful outcomes. What is the meaning of a mission statement? Why does it help to have a mission statement?
I've referred in my answer just now about the novelty point that lots of component parts have been worked through, the people cell, the clinical cell, everybody was doing good work. But it had got stuck because when you tried to add those pieces up, it wasn't clear how to make the right decision, right? That did vaccinate the right cohorts, that was technically doable, that was doable in a supply chain. And so I wanted something that really, in a very synthesized way, was really clear about what we were for, so that when we put things together, those difficult trade-offs about this cohort here versus there, whatever, we had a clear and agreed structure that said, well, so long as it's doing this, it's the right answer. So it both enabled different perspectives to come together and for us to make those trade-offs, but also I couldn't be in every decision that my team was making, and there were deeply expert people. They needed freedom to be able to make decisions without me. And again, they could say, well, if it's doing this, then it's the right decision. So it was a marshalling cry.
So in a very complex, necessarily part bureaucratic system, it gives everybody confidence to make a decision,
Yeah.
and it gives them a steer as to what the correct decision is likely to be.
That's right.
All right. You had in this system 7 regional directors of commissioning who were the heads of the regional teams. Were they responsible in each region for every aspect of deployment, from the technology, the tech, the data, strategy, planning, sites, supply chains, everything?
I just wanted to go back to the mission statement for a second. Sorry, there's one
Yes,
additional
of
thing, and then
course.
we'll answer that question as well. The other thing was about give people something to be excited about and to feel proud in. I think it's quite easy in these conversations to think about the things we can touch and feel, the processes, the reporting, etc. But how people felt about being part of this was also really important, and I think the mission statement was helpful for that. Sorry.
Your long career in HR must have been of great
you go.
assistance in that regard.
Back to the RDCs. The RDCs were responsible for the deployment of the programme locally, which did mean things like working with local systems to identify the right sites for vaccination centres. They were doing, GP engagement locally, that kind of thing. They weren't responsible for tech development or for, clinical policy, etc. That wasn't created locally. There were some things that were created nationally they would then deploy, and then some things they were sort of pulling up, if you like, from the local level.
Would you recommend the use of regional directors in the future, in the next pandemic, if there's a national vaccination programme, where each of those directors has more or less full autonomy within their area?
I wouldn't say they had full autonomy within their area. I would say they played a critical sort of corralling and decision-making function, but it was not the case that at any point, I don't think they would have suggested it to me, but if they'd come to me and said, right, in the Northwest, we're going to, we're not going to have any vaccination centres, for example, we just wouldn't have done that. So just to be careful with the language, I absolutely needed that connection between these single massive decisions nationally and the real intelligence that said, if you use that GP site in North Bristol, you're going to need another one here because nobody's going to cross that A road kind of thing. That they were the bridge between what we could see nationally and what they knew, and relationships they already had and brilliant work that was already ongoing in some places with individual communities. They provided the bridge that enabled us to do both.
So they were more closely connected to the local communities. They had the local links to directors of public health, for example, and they knew the best sites for vaccination, as well as how to get in amongst the local communities in order to improve take-up.
Well, and if they didn't know it themselves, because some regions are massive, obviously, they had the connections to the ICSs or the STPs as they were, and to the LRFs, and could encourage those local discussions to happen.
One of the core directives, if I may use that word, that you put into place was that no one would be more, or should be more than 10 miles away from a vaccination location, excluding, of course, housebound people. Was that a very different approach to that which is ordinarily used in the context of a routine immunisation?
Yes, partly because routine immunisations will tend to take place in primary care, which is by definition more local.
Because it revolves around GPs and
Yes.
clinical commissioning groups and primary care networks, all to do with primary care.
That's right.
In
Because-
England.
In England, sorry, yes. It's really important that pretty much everything I say is about England. And this programme, we absolutely intended to use primary care, and to get through the volume we needed these large-scale centres. I should add that the 10 miles became very catchy. Obviously, if you're in a city, 10 miles was sort of irrelevant. And later on, when we were looking at low uptake in areas like Leicester or London, my personal mantra was 3 bus stops away from somebody who can give you a vaccination. It's like it was it was a starting point to say that we'd really covered the country. And I was concerned about areas of rurality which look white on the map, like there's not many people there, but there are some people there. And I wanted them to be able to get a vaccination easily too.
Vaccination started in hospital hub sites on the 8th with, was it Mrs. Keenan who was vaccinated?
That's right.
And the evidence before the tribunal inquiry suggests that the first GP, or at least the majority of the GP vaccination, started on the 15th of December.
That's right.
Did you start with hospital hubs because in terms of scale they can deliver more vaccines in a shorter space of time? And of course this is a numbers game. You've got to get as many vaccines out there into the arms as you can, as quickly as you can. But also the issue of the freezing of the Pfizer vaccine, to which you've already referred.
That's right. We did not know until the 2nd of December that we would be able to transport the vaccine at fridge temperature. We thought we would. So my supply chain team was in the negotiations with the two pharmaceutical grade wholesalers to make sure we could set up that supply chain, but we didn't know. So given we had 6 days from that point to the first vaccination, which was agreed with the DAs as well, we needed something that was definitively doable, and that was hospitals. The second reason was that this was going to be the first vaccination anywhere in the world outside of a clinical trial, and we wanted the infrastructure, the safety sense of a hospital to be the location for that first week of vaccination, so we could keep a really close eye on what was happening.
And at a very high level, it's obvious that there was a move away from early centralisation in terms of yourself and NHS England producing and making sure the supply chains worked and the vaccines were delivered and the workforce was available and the vaccinations were recorded. And away at the same time practically from hospital hubs and GPs, so primary care networks, to mass vaccination centres and community points and pop-ups and pods and whatever have you. Would it have been possible, was it ever possible to have those more granular, specialised delivery sites, pop-ups, community sites and so on, and max vaccination centres available at the beginning?
We were, through November, we had our foot on the accelerator of all of the modalities because we wanted to be ready, not community pharmacy, to be fair, because it wouldn't have had the scale to start off with. It clearly wasn't the right place to start. We were equally clear we were going to need it. And we were doing commissioning discussions with community pharmacy at the beginning of December. It wasn't that we didn't want it, it wasn't yet. Mass vaccination centres were in the running until quite late in November. And then the issue of the freezers plus one of the core components of the programme that we haven't talked about, which is my focus on operational excellence, because I knew from reading the WHO reports that one way you improve vaccine confidence is by every experience of interacting with the programme is excellent. And at the end, middle to the end of November, it became clear the national booking system would not be ready for go live until January. So we would have had no way of booking people in to a mass vaccination centre. I didn't think that was going to go well. I was really concerned about that. So we had a barrier, which was the supply chain, and I think it was better that we waited to launch those until January. Also, a third complicating factor showed up, which was that the national protocol wasn't ready until around Christmas Eve, I think, was when it was signed off, and vaccination centres could not have safely vaccinated without the national protocol.
And the national protocol is the document, but we'll look at it in a moment, some might say very prescriptive document, yes, running to many, many pages, which tells everybody in the vaccination centre what to do.
Yes.
Do you assess that what you did, which was to start with hospital hubs and then very shortly thereafter move into primary care networks, the GP surgeries, and then move out to mass vaccination centres and community hubs and the more specific specialised sites to try to get to every sector of the population, worked? Or should we be thinking next time in terms of having mass vaccination centres and specific community sites up and running at the beginning of a vaccination programme?
I mean, I think realistically it will depend on the nature of the pandemic and of the disease and of the vaccine. what I'm hoping is partly through the inquiry we'll have that blueprint and that ability to test ready to go. I would say that I think starting in hospitals and GPs in particular, for the most at-risk groups that we had, which was the elderly and people in care homes, primary care was the right model. And if we hadn't been so sure of that, we probably wouldn't have pushed GPs as early as the 15th because of the complexity of the supply chain, et cetera. But we did because that was what our priority cohorts needed. You mentioned pop-ups. We started really doing pop-ups on the 16th of December when we started trialling in care homes. They were their own very special kind of pop-up, effectively. Yeah.
I want to ask you about that because it's recognised, isn't it, that hospitals, large hospitals, have a poor ability to reach high priority patients. The very elderly may have accessibility, transport issues, but also genuine concerns properly held about fears of infection, vulnerability by going to a large hospital. How did you meet those concerns, and how did you cope with, or how did you arrange for early vaccination of vulnerable, high priority people?
So this is where we actually changed tack on the 2nd of December. So we had been developing everything in parallel because of that concern around supply chain. As I said, that's why we were doing that. But because we became aware, again, around probably just before the 2nd of December, that we would not have enough vaccine in December from Pfizer to vaccinate all over 80s, even if we only did them. It became absolutely essential to vaccinate the over 80s. What we had planned to do was to start perhaps more with health and social care workers because they could travel to the vaccine. And we obviously would have started with the over 80s and GPs the following week. But that became ethically the wrong answer. So we pivoted actually on the 2nd of December with a webinar that I think I had on the 4th with all of the COOs who were running the hospital centres to say, right, you now need to work with us to figure out how to invite over 80s into your hospital because that is your priority group. And we didn't prescribe how they were going to do that. We offered support, but we asked them to work with their GPs. A couple of the hospitals used existing booking systems, local booking systems that they had, but we said, you need to work with your communities to bring the over 80s in that first week of vaccination.
And I want you, please, to say something about the sheer complexity of this process. In terms of logistics, there was a very significant problem, wasn't there, with the fact that the Pfizer vaccine couldn't be transported at a higher temperature than freezer temperature for more than a particular amount of time.
That's
and
right.
Indeed, its authorization required it to have no more than 2 journeys, I think, above
Once defrosted, yeah.
Above a certain temperature. And so a normal average-sized GP surgery wouldn't have enough time to split up and use the pizza box of doses within time before it melted and became unusable. So I mean, there were some incredibly complex issues to be resolved here, weren't there?
There were, yeah.
And in terms of the scale up, give us some idea, please, of the speed with which you scaled up from the 52 hospital hubs on the 14th of December and 116 local vaccination sites to the position in the beginning of February.
By the beginning of February, we had 1,270 something. I want to say 1,277, but I might have remembered the number wrong.
1293.
Thank you very much. I apologise I didn't get that right. But I have a lot of numbers in my head, of which the majority were local vaccination services, so a mix of pharmacy and the primary care networks, which we haven't mentioned, but I assume are somewhere in there, which were groups of GPs that had been established earlier in 2019 to put groups of GPs together at a certain scale. They became the right scale for vaccination. But that included all of our existing hospitals, so all 256 trusts, including community trusts, for example, were set up by the end of the month in order to vaccinate staff in particular, by the beginning of February, sorry.
And was an additional problem that the second dose And by February, of course, you've got authorization for not just Pfizer, but AstraZeneca.
Yes.
The second dose has to be the same as the first dose. Did that then mean that you had to try to put into place a system whereby a second dose would be available, kept available, and then delivered to the right person?
That's right. And it mattered much more that you'd made an appointment at the right place for the right vaccine on the right day. So the supply chain complexity where if it's the first dose, at the end of the day, if the GP's got vials left over, they had permission to not waste it, to vaccinate the next most sensible person. For a second dose clinic, it had to be the right people at the right time receiving the right vaccine. So it's a more complex delivery challenge.
And what was the obligation in terms of the time allowed to record in GP's records the fact of vaccination in every individual case?
In 24 hours into their record.
And was that something that was required by the MHRA or DHSC?
It's
or
in the national
self-imposed?
protocol.
It's in the national protocol, the document to which you've referred. All right. Now, I just want to now turn, please, to some particularly discrete and individual issues. On the 8th of December, 2 incidents were reported via the yellow card system of adverse reactions to vaccination. Was that anaphylaxis?
Yes.
What happened as a result of the reporting of those 2 reactions?
So those were flagged through the yellow card system. I was notified during the day through the mechanisms, and MHRA is the authority that's collecting the pharmacovigilance information. And they honestly can't remember who convened the call, but 11:30 that night there was a call with CMO, June Rain, JVT, myself, Steve Powers, National Medical Director, DHSC, so that the CMOs could look at the information. It could be considered, I can't remember if Wei Shen was there as well, to say, was this unusual or was this expected? Anaphylaxis is a serious but not unexpected reaction to a vaccine. And it was in that call that the decision was made that it was safe to continue the programme, but that we should introduce the 15-minute wait post-vaccination to ensure if something was going to happen, it happened on site, not when somebody was travelling home.
And was that significant tweak to the system put into place from the following day?
It was incredibly significant and quite lucky in a way that we were still only vaccinating in hospitals, which are large institutions which have space. If we'd been in GPs and they were, which we were only 6 days later, changing the space around would have been much more disruptive for them. As it was, we summoned everybody who was vaccinating to a call at 7:30 the next morning and said, right, you're going to need to change your layout, you're going to need to change your staffing model so that somebody can observe, and so on. And obviously we worked with GPs to adjust what they were planning for the following week.
And you'll forgive me for making what may appear to be a very obvious point. So from the time at which the 2 cases of anaphylaxis were reported to changing the way in which vaccines were delivered on the ground, all took place within 24 hours.
That's right.
The workforce, is this right? The vaccinators were generally organised and trained by part of the NHS, the integrated care system part of the NHS. But you also had available volunteer vaccinators from St John's Ambulance.
Yes, it's slightly different than that, if I may.
Please.
We use the ICSs as the central point of deployment of the workforce. Sorry, integrated care systems. So the 42 semi-local organisations which oversee the relevant part of the health system and have local relationships with local government, public health, etc., and social care. We wanted workforce to be able to be deployed locally. We were not sure at the beginning whether that would give us sufficient scale, whether there would be enough people in it, and also you might have some places with not enough people. And so we also put in place the national offer with the support of St John Ambulance and the Royal Voluntary Service. The training was done nationally. That was developed by PHE and Health Education England. and it was all done online, and depending on your level of qualification, you had to do different modules of that to be qualified as a vaccinator.
And to be clear, anybody who vaccinated, so that is somebody within a GP surgery or anybody within the primary care network, which is a combination of GP surgeries, anybody in a pharmacy or in a hospital or a mass vaccination centre or a community hub
Yes.
had to be trained according to a protocol.
Yes, and if they were not previously experienced vaccinators, they also had a period of observation and senior supervision to make sure they weren't just trained, they were actually confident in what they were doing.
So it wasn't enough to be a doctor or a nurse or a clinician. If you were vaccinating, there was additional training.
That's right.
Because the material before the inquiry shows that some people have expressed concerns about the comprehensive nature of the training and the degree to which you did train vaccinators. Were vaccinators trained in all aspects of the vaccination? So not just clinically how to deliver a vaccine into an arm, but in relation to the reporting of the vaccine, the reporting structure, as well as, importantly, safety and the possibility of adverse side effects?
Yes, there were multiple modules, and I believe, although I'd have to add them all up again, but the majority of the modules were specific to this vaccine and the nature of how you dispensed and delivered this vaccine safely, the specific potential adverse reactions for this vaccine.
Let's have a look at the protocol to which you've referred. It's the national protocol. This one is for Pfizer because it's Comirnaty. But 000486279, dated the 20th of November. There we are, Pfizer, valid from the 20th of November 21. So is this essentially the training document for the handling and the delivery of and the vaccination of this vaccine?
It's one of them. It's not the training material, but it comprises everything somebody's going to need to be able to do safely.
They're told to do what's in this protocol?
They are, yes.
All right. And we can just, if we could just scroll through very quickly from page 7 onwards. Characteristics of staff. So there were operational stages of activity to do with vaccine preparation, administration, record keeping, and this prescribed whether registered or unregistered healthcare professionals could carry them out. Is that right?
Yes.
And then you've got at the bottom of the page protocol stages. Over the page 8, the degree to which they had to have pre-existing training on top of this training in order to be able to carry out certain parts of the vaccination process.
Yes.
Over the page to 9, detailed prescriptive rules concerning assessing the patient who was presenting for vaccination.
Yes.
Over the page 10, cautions, so very detailed rules concerning the identification of conditions and reactions in the patient, everything from fainting to reactogenetic side effects, reddening of the arm and so on. And then very rare reports have been received of Guillain-Barré syndrome in the middle of the page. Past history of COVID infection, that's 10. And then we can, if we just scroll through 11, 12, 13, 14, through to 19, rules on dose, frequency of administration, action to be taken if the individual is excluded, description of treatment, drug interactions, off-label use, adverse reactions, advice, follow-up treatment, special considerations, and finally on page 19, non-responders immunosuppressed. Do you consider, Dame Emily, that there was any deficiency in the training processes? Obviously, you're not physically present in every single training site, but in the general obligation for training and the degree in which that training was prescribed?
I don't have any concerns about it, and I know it was robust in that one senior clinician notified me that he'd failed the competency assessment the first time round because it was so long since he'd last vaccinated and he had to do it again, and he was fine with that. He said, it's the right thing to do. I want to make sure I can do this properly.
Was he really fine?
I don't know, but he told me about it, didn't he? And he did then go on to vaccinate.
The NHS England operated a National Immunisation Management Service database called NIMS,
Yes.
into which data from another system, NIVS, was placed, along with data from a GP system called Pinnacle.
Yes.
Do you think that the database the databases which you used were sufficient and effective in terms of trying to exclude too many overlapping and overly complex databases?
Having been through it at the time and then gone back through my weekly reports from the tech team from November through to about April in preparation for this, I am sure that we developed something that worked in terms of keeping people safe, making sure that there was a record of their vaccination in just in case something happened, that worked for us to record that we were safely delivering the vaccine, that we were able to check up on sites to make sure they were using the vaccine they got. It did what it needed to do. It was complex because the architecture of various different health system, IT systems, which I'm assuming we don't want to go into, is really complex. And there was definitely a gap, which we may come back to, in terms of ethnicity and other data about individuals, which is not held as standard in those systems.
The issue of health data generally is extremely complex, and,
Yes.
it was in fact the subject of a review, as I know you know, by Professor Kathy Sudlow in November 24, so last year, and we'll come back to that at the end. But the problem, in essence, is this, isn't it, that there are systems operated by GPs which carry codes, SNOMED codes, that's to say, medical characteristics of the patient. But those records are not always as up-to-date or perhaps as accurate as they might be. And at the same time, there's no GP or general NHS system which includes occupational data, what your work is or your job is, and also ethnicity. So there's no general obligation to record ethnicity either at the point of access to NHS services or at the point of recording of vaccination. So did that make it extremely difficult when you were asked, how can you best reach out into the community, for example, amongst ethnic minority communities, and see what we can do to encourage take-up? You didn't know precisely what degree of ethnic take-up there was of vaccination.
We didn't have entirely robust data, at least initially. It got better as it went on, which we can come back to. Actually, many GPs, not all, had some ethnicity data recorded. It was inconsistent, but it wasn't zero. And indeed, we can come back to this, but some GPs did also have a record of whether somebody was a carer or not. As you say, it wasn't mandated. But NHS England had, to some extent, looked ahead at this, and already in September 2020, had written to all GPs to say, please, can you review your holding of this kind of data, not carers actually, but ethnicity data, and where you've got it, can you make sure it's updated into systems, partly as a reaction to some of the initial events of the pandemic before we got to vaccination. So we were working on it, but you're right, it wasn't complete.
But was that letter in part why the process got better, and you managed to get better data over time?
We managed to get better data over time, partly because we then also started, I think, towards the end of January, not because we didn't want to do it sooner, but because it took that time to engineer it into the systems, asking for ethnicity data at the point of vaccination.
In sites,
Which we hadn't done initially for reasons we can come back to. But what we were able to do through using Foundry, the Palantir product, what that is particularly good at is taking different data sets and then using the characteristics of those data sets to put it together and say, this is almost certainly the same person. So we were looking at cuts of ethnicity data already, certainly towards the end of December. It just wasn't complete, and I couldn't absolutely put my hand on my heart and say we had everybody, but we had indications relatively early on that.
So in essence, the structure is there, but it's patchy in terms of its output. I will ask you now about Professor Kathy Sudlow's review of the 8th of November 24, the health data review. Amongst the 5 recommendations that she makes, there are 2 of particular relevance here. she suggests that key government healthcare and research bodies should establish a national health data service in England with accountable senior leadership, and also that national health data organisations and statistical authorities in the 4 nations should develop a UK-wide system for standards, i.e. not overly prescriptively demanding that there be a national data system across the whole United Kingdom, but at least agreeing standards so that each nation can have compatible and sufficiently proper standards for sufficiently proper data systems. I'm sure you had something to say about Professor Cathy's review. Do you endorse those particular recommendations in the context of trying to roll out a vaccination programme in the future?
And the shorter answer is yes, if I might just elaborate
Please.
for a second. I mean, the second one, I don't think anybody would argue with, and indeed, the issue of people who were vaccinated in an English centre but had a Welsh NHS number went on for a while before we could solve it, and vice versa. So absolutely having agreements about how we do that and consistent data would be hugely valuable for public health as much as for anything else. The work I am engaged in and sponsoring at the moment is to try to get most particularly to a single patient record in stages. I think it would be of huge benefit to the patients. And the thing I absolutely endorse Dr. Sudlow's report. The criticality here is it's integrated for the patient. You mentioned SNOMED codes. The reason SNOMED codes are not always current is because somebody in secondary care issues a clinical decision that is then sent to the GP, who has to then update the primary care record. Some systems have integrated the records, but by no means all. So from a personal user perspective, you want every clinician you meet to be able to understand what's going on with you, and that isn't always the case, and that would be the biggest advantage, I think, to the individual. The
precise medical condition for which the patient has presented himself or herself needs to be recorded, along with their
everything else,
occupation, if any, and so that when you dig into the data system for the purposes of deciding who needs to be offered a vaccination, who needs to be approached to be encouraged to take it up, and who gets it, you've got it all, as you say, in a single point.
In a single point, and because that person then has a better experience of care. The thing I think that's important that we consider as we go along, which Dr. Sudlow does talk about, is we have to bring people with us, right? Because for at least there is a general acceptance in the UK that this would be a good thing. People are happy for their health data to be used to make their lives and their care better. But there is that level of distrust about what your data is being used for, particularly in some communities. What I wouldn't want is for people to not come with us on that journey and feel that their data is going to be used for purposes that they don't consent to. And I think we have to do that work at the same time.
Thank you. Well, that's very clear. There came a time when the decision was made to move to a 12-week second dose cycle for Pfizer and AstraZeneca. And we've heard evidence as to why that was so. Did that present itself as an extraordinarily complex shift in position as far as you were concerned, in terms of changes in supply allocations, the bookings, the workforce arrangements, and what to do about people who'd already agreed a second appointment?
Yes.
All right. You were able, within a relatively short space of time, to completely change the direction of the system.
Yes.
There were, in the press and elsewhere, and in political circles, from time to time, criticism of the rates of vaccination. Did you produce a bar chart which showed the levels of delivery which you were planning for and hoping to achieve against actual delivery?
Yes.
Could we have your statement, please? INQ 000492335. Thank you very much. There it is. We can see there that as at the 19th of January, so we're within really a very short space of time after the first vaccine delivery, you had planned for and promised a certain level of delivery. Did you meet that plan and get the number of actual doses out that you'd promised you would? In
general, we did. I believe if we looked at this from a month later, there were some weeks where we were within shooting distance, but not exactly on the number, which always pained me. And it was obviously subject to supply fluctuations, which did happen over the towards the right-hand side of this chart.
But presumably, you received updates hourly or at regular intervals during the course of every single day as to the rate of vaccination.
Yes.
You must have pored over the charts and the figures.
Yes.
The whole time.
I had a dashboard which was always open on my desk.
And presumably, you made available to the public and to the rest of government update figures on levels of vaccination.
Yes.
Daily, weekly.
It changed. It started off with a weekly publication. It moved to daily on the 11th of January, the Monday. And over time, we then did an automated feed straight into the Cabinet Office of certain metrics so that we weren't providing the report. They were getting automatic data updates. And then there were other data sharing agreements with other parts of government.
You mentioned the national booking system earlier.
Yes.
It started, I think, on the 9th of January. That was its full operational launch. Why was it not possible to have in place a national booking system at the point of the commencement of the vaccination programme on the 8th of December?
I mean, partly it wasn't, we didn't think it would be required earlier. Secondly, this was being built from scratch, building off of these incredibly complex systems that don't talk to each other that we've already described. And it needed to be simple, it needed to be incredibly user-friendly, and it needed to work as a front end, and then it needed to be pulling data from these multiple sites about what actual availability they had, which they had to plan based on what supply we were sending them and what workforce they had. So this was the system that was going to have to be the front end to a lot of complexity underneath the surface. I was very keen, as I've described earlier, that we didn't launch it until we knew it was going to work. And
because in terms of confidence, collapse system is disastrous.
Well, and also being offered a vaccine booking 100 miles away from where you live was just not going to be good for the programme. It was going to look like it wasn't accessible, that we hadn't thought about location. So we had to work very carefully to try and put the right wrapper around that. And despite pushing really hard, my tech lead, Adrian Sandbury, who started at the beginning of November, came to me, I think it was probably like the third week of November, and said, look, it just isn't, I can't push it that hard. It also had to be clinically safe. There was a clinical sign-off process as well. So there was a bunch of stuff to engineer into it.
Is there a national booking service for routine or childhood immunisation?
There wasn't one, no.
And so ordinarily one would have to wait to receive a letter or a text saying you are being invited to come in for vaccination or immunisation.
Yes, so the school vaccination of flu, for example, which my son gets, that's how you get it. The Red Book vaccinations, the ones that happen in early childhood, tend to be done through routine appointments where people are going to their health visitor or GP anyway. But if people don't come, then yes, they would get an invitation that way.
There was no online ability before the 9th of January 2021 for anybody to go to an online site and book themselves an immunisation or vaccination?
Certainly not from a national perspective. Individual local systems may have had something I'm not aware of.
All right. Relationships with devolved administrations. Did the vaccinations commence on the same day in each country?
Yes, for both the first Pfizer dose and the first AstraZeneca dose on the 4th of January.
Was there a close degree of cooperation between yourself and your fellow SROs in the other three nations?
Yes, very much so.
And did the SROs join critical meetings held by the NHS England as well as UK governmental meetings?
Yes, so they were all invited to my operations board, which used to happen every Monday morning, just so they could stay in tune with what we were doing and challenge it if necessary.
Public health is a devolved issue.
Yes.
So it was absolutely within the ability and the right of each nation to decide for itself how to deploy vaccines.
Yes.
At what point did each nation take over the deployment process? Was it from the arrival of vaccines within the geographical confines of the United Kingdom, or was it from the point at which they were delivered to Public Health England warehouses, or what?
So for England, it was from the PHE warehouse. I think that was, I'm trying to remember, I think that in a couple of instances, there was direct vaccine supply into one of the countries, but I can't now remember. I remember the discussion around this, but
Broadly, we
took over from PHE, yeah.
Task force organised procurement and delivery into the United Kingdom.
Into the PHE warehouse,
where physically each nation would take over what happened to the vaccines thereafter. How important was it that even if you weren't in lockstep, each of the 4 nations broadly agreed on how vaccine delivery would be prioritised and physically made available?
I think it was incredibly important for public confidence. I mean, we're not, well, getting into a political statement, but we are the UK. The VTF was operating on behalf of the UK. The countries had made a decision to buy vaccine together. It was important that the citizens of each country had a similar, if not exactly the same, experience of being vaccinated or being offered a vaccination.
You obviously spoke the whole time to your fellow SROs and you WhatsApped each other frequently. Can we just have INQ 000477804, page 22, please? This is an example of your communications. It happens to be the 22nd of February in the early afternoon, where Naresh Chadha from Northern Ireland, Dr. Chadha says, we're having a bad day at the office today, unpaid carers. Derek Grieve from Scotland, been there, got the T-shirt. Gillian Richardson from Wales, yes, agreed. Derek, Emily Lawson, we're also using broader definition as people.
Yes.
PPL with carer designation from Department of Work and Pensions are more than the JCVI. So in relation to almost every aspect of how to apply prioritisation in practice, how to broaden it out operationally, as well as the physical and technological aspects of getting vaccines into everybody's arms, was debated daily between you all.
Yes.
I don't think we need to spend a great deal of time on it, but no doubt there were times of turbulence where you disagreed on particular aspects. By and large, were those points of turbulence induced by events in the media or communications or public sphere, particularly the political sphere, where somebody would say something and then you'd all have to speak to each other and go, well, you didn't really mean that. She said that out of turn. This is the real position.
Yes.
All right. By and large, do you think that process of communication between yourselves worked very well?
I think it was incredibly helpful, the sense we were all in it together, rapid testing of things that were going right or going wrong, and then coming back together formally each week to make actual policy decisions supported by the Department of Health in our weekly DA SRO meeting.
Now, just even more briefly, a handful of remaining areas. In relation to digital exclusion, there's been a great deal of evidence before the inquiry as to how GP records were critical in inviting people to vaccination. But there are gaps in the data.
Yes.
There are gaps in relation to Home Office data on asylum seekers and refugees. There's gaps in local authority data on those sleeping rough, homeless, and those in accommodation, and also a lack of data for Gypsy traveller and Roma groups. How did you get around those obvious and well-known problems with being able to identify reasonably everybody in each community?
So to start off with, the NHS number was pretty foundational, not necessarily registration with GPs. So if you look at the enhanced service agreement with GPs, and even in its first version in, I think it was the first week of December, might have been last week of November, it specifically says GPs are on the hook to vaccinate unregistered people. So we were conscious of that. And we did do work to try and get more people to register to overcome that, because obviously it's an opportunity to get people more engaged in healthcare. The real challenge was not having an NHS number.
Why does having an NHS number matter so much?
Because it is the link to the records that we hold on you. So it is a critical safety issue in that it means that somebody can check, what other treatments you've had, for example, and whether you have a risk of, of bleeding, for example.
So you don't need an NHS number to get a vaccine. You could turn up at a mass vaccination centre. But in order to be able to bring yourself to the attention of the state and so that it knows whether or not you need extra assistance or extra help, or whether you need to be, to use the expression we don't really use anymore, reached out to, you need to have that data. And the data is going to be, by and large, in the NHS system. Without registration or a number, it's not there.
Yes, and you don't have to be registered with a GP to have an NHS number. If you've ever shown up to a hospital, you will have been given one. The issue was our systems were built around people having an NHS number. So check-in at a hospital centre, NIVS, required an NHS number. We made it easy to find it. You could do an immediate lookup. We didn't want you to not get a vaccine. So we knew from the beginning we were going to need a workaround for people who didn't have an NHS number. It was also required to use the MBS to start off with. And so I'm not going to get this completely right, but it's on our list of tech issues from early December. And by the time we get to the end of January, we've agreed a workaround that is clinically agreed for the safety reason that you've just articulated, but that would actually be designed into our system so that we could systematically vaccinate people who didn't have an NHS number, although we would obviously encourage people to register as part of the vaccination programme. And communicating that became very important, particularly less so to Gypsy, Roman and Traveller, where more the engagement and finding them sites that were convenient and often taking the vaccine to them was critical, like going to Appleby Horse Fair, for example. But for migrant groups, some of whom were very concerned about how their information would be used, being able to be vaccinated by that one was actually essential. And the best example of that was a pop-up that the London team did in Soho in relatively late, sometime in June, I think, specifically advertised as you don't need an NHS number, and it had 2,000 people show up. So there was that pent-up need. It took us a while to design it into the systems.
Presumably, as the national director, you couldn't know and you weren't told of specific problems in accessibility in individual sites, in particular, for example, for disabled people. But did you put into place systems by which you hoped that the majority of accessibility issues would be tackled, addressed and dealt with?
Yes, the service the specifications for any vaccination centre said that they needed to be accessible, and the information about what accessibility was offered was built into the NBS, so people should have been able the National Booking Service. So it said what that centre had, including what translation was available, for example.
And of course, there will always be gaps. There may be individual sites where things didn't work as well as you would have wished. Was there a standard, an NHS or UK government standard, which was applied in terms of what the vaccination centres had to do in terms of making themselves accessible to, in particular, disabled people?
Yes, there was.
All right. And was that adhered to, at least systemically?
I mean, as far as I knew, and it was part of the sign-off that the regional directors of commissioning did when they agreed to a site going live, was that those conditions had been met.
In general terms, in relation to addressing disparities in uptake, is it ever possible to deliver healthcare services to everyone who needs them?
The short answer to that is no, because we're dealing with societal inequalities which are not under the control of the health service. So we have to do everything we can to come to where people are and design services that work for them, including vaccination.
More specifically, in relation to vaccines which are being offered prophylactically, i.e. to people who aren't ill already, is it ever possible to reach 100% uptake?
Not in every segment of the population for every vaccination. We got pretty close to 100% in the cohorts that felt most at risk, I would say.
The uptake in England for 2 doses for over 12-year-olds by the 30th of June 22 was 83.7%.
Yeah.
Do you think that was a credible outcome?
I think it was a credible outcome given the original planning assumptions before I took over had been 75% uptake, not including children. It doesn't mean that I think there wasn't more we could do. There's always more you can do, but I think it was a good outcome.
At every administrative or political level, was the issue of disparities in uptake appreciated, acknowledged, and sought to be dealt with?
Very much so. I had an equalities team. They were on my leadership team. They were in every discussion. We established the Vaccine Equalities Board, which met before we had the vaccine on the 1st of December and ongoing. When I go back to even before I joined the programme was engaging, for example, with the British Islamic Medical Association in October to ask about, what would need to be true for people to be able to support the vaccine. So, I mean, I won't give you the list because it's in the witness statement, but it was ongoing engagement and feedback to see what could we do to keep improving.
Could you look, please, at 0000063195, page 2. This is a readout, to use the governmental word, or a list of actions from a meeting with the Prime Minister dated the 12th of January 2021.
Yes.
The Prime Minister asked what is being done to access the harder-to-reach communities people and what more can be done. He asked that the NHS work closely with the Ministry of Housing, Communities, thank you, and local government and
They
local
will keep
authorities.
changing their names.
Yes. And local authorities, thank you, to provide them with everything they need to maximise rollout and uptake. And then there's a reference to Simon Stevens, the head of the NHS. The Prime Minister pressed for data to be made available as soon as possible. The Health Secretary referred to the approach to being able to address disparities in uptake. And the Prime Minister then asked the CMO for his view on the relationship between NHS and local authorities. Was there any doubt in your mind that the issue of how to address barriers in uptake and pre-existing disparities, particularly in healthcare, were being addressed at every turn?
I think on the 12th of January, I would say it was absolutely top of mind. We were holding regular meetings on it in terms of taking some of the really good examples like the one that's cited here in Dorset and scaling them. We were in the early foothills of doing that. And I think what really changed we did, by the way, make sure that the data was shared by, we started the full-on data sharing on the 15th of January, so just at the end of that week. What we were able to do starting around this time, because we weren't so limited by the supply of vaccine and because you had AstraZeneca that was more stable, easier to distribute, came in smaller packages to start off with, just the creativity that local systems could apply to outreach started to really take off.
Right.
And because a lot of the outreach and sort of small scale, it takes a lot of people to deliver one vaccine, was being used in care homes at this point. And then we get towards the end of January, most of that work is completed. Most care homes have now had at least one visit. There's then more capacity to do further engagement and outreach.
On specific communities.
Yeah. Plus, communities started to come forward more. If you may not remember, but the conversation publicly about the vaccine programme over Christmas and into the new year wasn't great. It was kind of going to be another example of failure. By the time we've shown how much ramp up you saw in that chart you showed earlier, by the time you get to certainly the third week of January, it's like, oh, this actually might be a success. And that encouraged lots of people to say, well, I want to help, I want to come forward, I've got this idea. And so we have, for example, the first mosque as a vaccination centre opening, I think on the 21st of January. The Crawley bus, which was a local initiative, didn't come from me, at the Hindu temple there, was on the 28th of January. So just that local engagement and creativity starts to really take off at this point.
And presumably there were a number of plans and actions put into place to generally increase uptake and to encourage people to come forward. I think Grab a Jab, was that one of yours?
Well, yeah, Grab a Jab came from us and was actually carried out by my Chief of Staff, Ellen Graham, who put the whole, corralled putting the website together over a weekend in May. Grab a Jab was a good example of adjusting to a new cohort. So we now had, because we vaccinated down to sort of age 50 by the beginning of April, so we were now vaccinating those in their 30s and 40s, and they had really different needs from vaccination centres. They were less bothered about appointments, they needed more out of working hours, etc. And so Grab a Jab was an example of, you're just spontaneously going to decide to have a vaccine this weekend, here's where you can go, and made it more of a social activity, partly because lockdown was ending, so we needed to make it even easier for people to get a vaccine, because that sense of urgency when you can't see anyone had slightly started to dissipate.
Let's look, please, at the the vaccine uptake plan. This version is the 5th of February 2021, so around that time. 000330899. Did this plan have a number of iterations?
Yes, absolutely.
If we look at page 3, we can see statistics as at the 3rd of February. The proportion of people aged 80 plus who have had their first dose by ethnic group and deprivation. So may we take it from this and the fact that this is in your core vaccine uptake plan that you are constantly looking at percentages of uptake across different communities?
Yes.
The reason we note, and you reference here to Gypsy, Rome or Traveller, would we find figures specifically relating to them anywhere in the NHSE documentation?
No, because it wasn't at the time in the, what's the right word, the definitions of how ethnicity data was collected. That's in the process of being updated at the moment.
So how would you know what the level of uptake was in that community?
We wouldn't have known nationally. It was the kind of thing that we asked local systems to report to us on. Those that had local Gypsy, Roman traveller populations, we asked for sort of sit-rep information to say how that was working.
And did you get it?
Yes, we would. I would not at a level I'd want to report in national statistics. I don't think the national statistician would think it was robust, but it gave us an indication of the kind of thing that was happening, partly so we could share that with systems that were perhaps further behind.
Sorry, no, do continue.
It was just the PM paragraph that you pulled out earlier didn't mention this, but this chart is very good on it. There were real challenges, obviously, with different groups not feeling confident to have a vaccine or not finding our offer convenient at the time. But what this chart shows really clearly on the left-hand side is that there was also an intersection with deprivation, that the more deprived you were, the less likely you were to receive want a vaccine at this point. Even in the white British group at the top, it's lower on the left than it is on the right. And so we were conscious of that in terms of where we put the next wave of vaccination sites, for example.
Page 5, there are references to the work underway, the actions for removing barriers to access and for improving take-up. Presumably these are very broad descriptions, headlines only of what was actually being done, but we can see reference to resources, funding options, working with national partners, videos, roundtables, communication material and so on.
Yes.
In your team, were equality and health inequality impact assessments carried out?
Yes.
What were they?
They were sort of a policy assessment to make sure that if you put this in place, you're not going to, you've properly considered the equalities impact and hopefully made it more positive, not more negative.
And was there something called a vaccine equalities mapping tool to investigate the links in data between locations and take-up, and a vaccine equalities committee to try to guide you as to how you could best improve take-up?
Yes.
It's clear that a lot of the work had to be done at local level. So engagement with local community leaders, developing a network of trusted voices, local media and social activity, local grant interventions from baxi taxis, hopper buses, clinics in churches and other faith buildings and social venues. Who in practice was at the local authority end of all that planning and work? Was it the local authorities, the administrative structures there? Was it directors of public health, How did it work in practice?
I would say it was a real mix. So quite a lot of those initiatives built on existing relationships and outreach that was going on even before the pandemic. So the particular strength in the Southwest, for example, where we got a lot of innovation was because they'd been doing such strong health inclusion work for a really long time. So it might have come from, it often came from the voluntary sector, so from specialist groups like Groundswell, for example, on the homeless, because they knew what was needed by their groups and they would either engage locally with people they already knew, often in that case, the local authority, or it might have come, and those local initiatives you say were critical. We did also get some national approaches. So the Bangladeshi Caterers Association approached my team directly to say, in the Bangladeshi community, almost everybody's connected to somebody in a restaurant. So
you
why don't
arrange vaccinations in restaurants?
Yeah, so why don't we, and they sponsor, you know, we provided support, but they cracked on and did it. They spoke to their own community. And one of the big successes of this is, you've just looked at the data from the 3rd of February, between the 7th of February and the 7th of April, the uptake in Bangladeshi communities went increased 5-fold just in 2 months, which showed that if we found the right engagement and the right ownership in the local community and individual communities, it made all the difference.
Your statement shows that the NHS England published videos featuring people with learning disabilities and autistic
Yes.
people. And the evidence before the tribunal shows that there were a number of projects endeavouring to focus on increasing awareness of vaccination amongst disabled groups and also trying to overcome the obvious problems of accessibility. One of the problems that appears to have arisen, however, is that no one appears to have been quite clear who should be offered a vaccine on account of the fact that they suffer from a learning disability, because there was a lack of data as to, well, the systems for reporting, the registers for reporting learning disability were not entirely accurate, and no one appears to be quite clear as to what degree of learning disability one would have to suffer before one would even get onto the register. Was that problem circumnavigated in the end, or was it a constant running issue?
Can I say both? In answer to that, I mean, it was, we were lucky in England that we had a learning disabilities register to start off with. I don't think that was the case in all of the DAs, but so we had a starting point. And it was one of the things, again, that NHS England wrote to systems about in the autumn of 2020 to say, please, can you make sure you're updating this, partly, again, because of the increased morbidity and mortality among people with learning disabilities earlier in the pandemic. So we had a start. We did a huge amount of engagement with clinicians and with communities on the SNOMED codes as we went into cohort 6, because there were potentially thousands of these individual classifications that needed to be included.
And they, in general terms, they were meant to be and were anticipated to be within cohort 4 and cohort 6.
Yes, depending on yes. And indeed, Down syndrome moved from cohort 6 to cohort 4 because further data on morbidity came through. So we did all of the engagement. I absolutely will say that, you know, had we had the complete register to start off with, we would have been in a better position. But I think we both had a decent starting position and we worked really hard to improve it. And we tried to build into that what would really work for the people that were needed to receive the vaccine.
Then finally, you've taken the care to set out in your statement lessons learned and some recommendations. We've discussed briefly the nature of the NHS system, but its branding, its unitary nature, and its systems. You appeal to or you extol the virtues of working together, asking for help and receiving it, being well funded, and also being able to have access to and being able to use proper, accurate, up-to-date data.
Yeah.
All of which are laudable but quite general appeals or recommendations. Have you seen the expert report prepared by Dr. Casander-Bush and Dr. Chandler on the issue of deliveries? I just want to read out and summarise 6 of the recommendations they make, and I just wanted to ask you whether you would agree. The keys in future are closing gaps in routine programme delivery by addressing more aggressively barriers to access, having national communication campaigns reaching out into groups, particularly ethnic minority groups, but any groups where there are high degrees of vaccine hesitancy between pandemics. Long-running and entrenched inequalities need to be tackled between emergencies by using local place-based partnerships. There needs to be better identification of priority risk groups, for example, people with conditions that are not recorded in patient notes, learning disability registers, for example, or unpaid carers. An expanded vaccination force ready to go, consisting perhaps of health visitors or through having already trained primary care teams. And lastly, although I'm not expecting you to comment on this one, the importance of instilling and maintaining high levels of public trust in government, because the flouting of public health rules by government tends to undermine confidence generally. With the exception of that last one, which I'm not going to put you in the awkward position of answering, would you agree with those general appeals by our 2 experts?
I absolutely agree with the direction of those, and it's an incredibly detailed report. I think considering that alongside Dr. Larson's report as well, looking at hesitancy is really helpful. I think for some of them it's worth thinking about how they would be operationalised. I mean, we are not short of vaccinators day to day for doing the routine activity. So one of the things, just as one example, what I tried to reflect in that closing bit of my personal statement is I recognise it's really hard to spend taxpayer money on things that you don't need at the moment. So I think there is an element of for the Treasury and the government rather than for me to think about, A, is there something it can be doing now that then enables it to do something different in a pandemic? And secondly, what level of resilience do you want to build into, obviously not just the health system, but more broadly? And that's a really difficult decision.
You have no trouble at the moment, do you, with finding enough vaccinators for routine immunisation?
No.
And the evidence shows you scaled up a huge number of vaccinators to deal with COVID.
We did, and most of some of those were volunteers, but in fact we underused volunteers, right? Lots of people volunteered we didn't end up using because we didn't need them. So I think, for me, the point from more broadly from the pandemic on this particular issue, rather than just for vaccination, is the energy that local communities had to get together and help the community, partly in vaccination, partly in other parts. The volunteers early on for people who were housebound, for example, which my dad benefited from. There feels to me like there's something there about more broadly, how do we use volunteers? How do we capture that spirit of actually wanting to help? And that might have more sort of extended use rather than just for vaccinators.
Do you think there was enough use of health visitors and pharmacies?
Health visitors, I haven't looked into in detail, so I think everybody was mobilised locally who wanted to help. Whether we could have used more of the health visitor expertise, I'm not sure, perhaps particularly with particular parts of the population. Pharmacies, as I said, we didn't start in pharmacy for scale and complexity reasons, but we really used pharmacy. By the end of the relevant period, there were just under 21% of the COVID vaccinations had been delivered in pharmacy, so they kept going. And in the recent campaign, the winter campaign for flu and COVID, they did over 40% of the COVID vaccination. So the role that pharmacy plays in vaccination, particularly in areas of which are underserved by both primary and secondary care, is absolutely vital. There is one other one I just wanted to quickly react to, which was the communications one. I think national messaging was really important. I think there were some really powerful campaigns. But for people who are inclined to not trust government or big organisations, actually trusted voices, somebody you know or somebody who has a similar background to you, who's speaking in a different language perhaps, preferably who's also clinically qualified, it's quite specific, but trusted voices were that much more powerful when people were already concerned. And I think we should make sure that's part of that overall sort of broadcast strategy. Some messages are better delivered in a quiet conversation that maybe doesn't end up with vaccination, but does end up with you feeling more confident overall. And those 3 C's of confidence, complacency and convenience that were built into every part of the programme, I think they're very well reflected in the expert report, which is brilliant.
Thank you very much.
Thank you, Mr. Keith. Ms. Douglas, I think you have a few questions. That away.
Thank you. Can you hear me okay, Dame Emily? Thank you.
Yes.
I act on behalf of clinically vulnerable families who represent the interests of the clinically vulnerable, the extremely clinically vulnerable and the immunosuppressed. And I have just one question, and it relates to models of vaccine delivery. We've heard your evidence earlier about the efforts made to get the vaccine to over 80-year-olds and people in care homes in the early weeks of the rollout. And you've described at paragraph 202 of your statement the steps taken by NHS England to ensure that certain housebound and disabled patients were able to receive the vaccine. Many CVF members, in fact, had to travel significant distances to vaccination centres, and a pressing concern, particularly for those who had been shielding up until then, was the risk of contracting COVID-19 associated from travelling to be vaccinated, either from public transport or when being driven by someone in the close confines of a car. CVF's members also report safety concerns about some vaccination centres, for example, them being very crowded with poor ventilation. Given the particular issues for clinically vulnerable people who are being asked to travel long distances, why were strategies not developed for delivering the vaccine at home to these high-risk groups who may not necessarily have been housebound or physically disabled?
Thank you. So I hope it is clear from other parts of the statement and from the service specifications for all the different modalities that the centres being safe was a really critical part of delivery, and they were expected to uphold at the time masking and social distancing. And that, as I said, that would have been part of the sign-off process that they were doing that. It's equally clear from the individual experiences you're recounting that that wasn't everybody's experience, which is obviously, incredibly disappointing. I would have expected those kind of issues to be reported in the local system and then managed locally, and if they were consistent, then to have come back to me. And I don't recall them coming back to us nationally. A few individual complaints did, but not those kind. So that doesn't make it, okay for the people that experienced that, but I don't think it was a wide problem. I think centres were very conscious of being careful about social distancing. And I remember one example in Newcastle where they had people queuing outside in the snow, which also worried me because people had come too early for that vaccination. So I think we had lots of different needs that were being juggled operationally. It was part of the system and it was part of the oversight, the safety of the site. You also talked about travel. We expected clinically extremely vulnerable, so I think we're particularly talking about cohort 4 rather than cohort 6. Let's say yes for it. That they would largely be vaccinated by their GP because their GP was holding the shielding list, and indeed local authorities would have been also aware of who they were. So that should have dealt with some of the local travel issues, and I would have expected their GP to be close to them. It may well be that in a few places the local PCN perhaps wasn't vaccinating at the time. We would have always wanted to work to make it convenient. The definition of housebound was a clinical definition that the programme itself didn't develop. It was important to limit it, though, operationally, because obviously it was incredibly low volume. So given that we needed to reach a whole cohort nationally, we had to balance individual needs with the local population needs. I thought we struck the right balance, but clearly for a few individuals that didn't manifest.
Thank you, Ms. Douglas.
Thank you.
Ms. Beattie, who's that over there?
Thank you. I ask questions on behalf of disabled people's organisations.
In late January 2021, you authored a discussion paper for the NHS England and NHS Improvement Board meetings about the progress of the vaccine deployment program. And could we bring that up on screen, please? It's INQ 000 414427.
Could you go on with the question while it comes up?
Yes, certainly. At page 3 of that document, at paragraph 13, you wrote that the NHS is providing local authorities with visibility on uptake in their communities so they can target engagement appropriately. Mr. Stephen Russell, in his corporate statement for NHS England, confirms that overall data about disabled people is not available from the National Immunisation Management System. So given that disability data was not recorded, how did local authorities have visibility of vaccine uptake by disabled people in their area so that they could target engagement appropriately?
So this line 13 is the one from my board paper, is that right?
Yes, and I apologise if it hasn't come up. Yes.
No, that's fine, I've got it now. So I think you're partly asking a question about data and data recording about disability, is that right? And about engagement with local authorities on that?
Yes, the question is that we've been told that the National Immunisation Management System did not record disability data, which we understand to mean there was no disability data recorded other than perhaps a CEV code about when someone came for vaccination. Is that right?
It would have contained any information that was in the SNOMED codes for cohort 6 as well, so some learning disability, for example, but not physical disability, which wasn't part of the extra morbidity and mortality as defined by JCVI,
And it wouldn't have contained any disaggregated data on disability by impairment type, for example?
Outside of learning disability, no, I don't think so.
And so given that disability data was not recorded, how did local authorities have visibility of vaccine uptake by disabled people in their area so that they could target engagement appropriately?
So I'm not aware that local authorities would have had such a data collection. What did happen, as we discussed with the Gypsy, Roman and Traveller groups earlier, where that's not in the data collection from your GP record and therefore we can't use it to correlate with your vaccination data, is that local engagement, particularly with voluntary and community groups, would enable local authorities to say, well, we've got a particular gap here. They wouldn't have had precise, it's 15% of disabled people, for example, but they would have known, there is a problem with access in that the local bus route doesn't take appropriate support in order for people to get on it, etc. That is something that local authorities would have been able to do through relationships, through their local directors of public health, and through the overall uptake information.
But it's right, isn't it, that the National Immunisation Management System was commissioned in 2020 as a new system?
In the summer of 2020, yes, it was.
And is there any reason that disability data could not have been collected at the point of vaccination in that system?
I don't know, and I'm happy to write back to the inquiry on this, whether there are definitional codes already in NHS systems which NIMS, that Immunisation Management System, would have had to draw on, like, for example, Gypsy Roman Traveller is not in the dictionary, or wasn't in the 2001 census definition. So I don't know if there is something to build off or if it would have to be a new data collection, but I'm really happy to write back and say exactly what the status was and what the work is ongoing to address that.
So if there is indeed a gap, which is what we understand the evidence says, would you agree then that that's a necessary improvement that should be made to fill that gap?
Yes, depending on recognising it might take a fair amount of work to get to agreement on the definitions in the first place. Being able to look at that data, I'm sure, is something local authorities would would find very helpful in terms of commissioning of services, for example.
Thank you, Ms.
Thank you,
Beattie.
Madam.
Very grateful. That completes the questions we have for you, Dame Emily. I'm sure we're extremely grateful to you for the work that you did during the pandemic and for assisting the inquiry, both in your statement of evidence today. You're obviously very measured in your responses. And I was very tempted to ask you about the difference between the private sector and the civil service, but I won't, given the time. Thank you very much indeed for your help.
Thank you very much.
10 o'clock tomorrow.
All rise.